Hey everybody, welcome back to the You're Not Broken podcast. GLP-1s, what are they? Are they for everybody? Will the price ever go down? And is there a best practice to take them? Thank you so much for my friend joining me today, Dr. Rocio Salas-Whalen. Thank you for coming.
Hi everybody. Thank you for having me.
And you're an endocrinologist in Manhattan, in New York.
Yes, I'm endocrinologist and obesity board certified in the city.
And I feel like, when GLP-1 started to get big, last year, you're like, yeah, we've been doing these forever.
Yeah,
And
I think
they came out of nowhere, but they've actually been around for a while. Can you give us a history of them?
so the first FDA approved GLP-1 back in 2005, and it was named Bayera, and this was for type 2 diabetes. Now, back then, also an injection. They're all subcutaneous injection. We have an oral one, but the body absorbs it better if it's subcutaneous. And it was first indicated for type 2 for the treatment of type 2 diabetes. And then in 2010, that was a twice a day injection every day. Then in 2010 came Victoza, Saxenda in 2012, and this was one a day injection. Also for diabetes, then 2012 for weight loss independent of diabetes. Then 2017, the poster child of them, Ozempic, came out. And then 2022, Wegovy. 2023 was Mounjaro, and then last year, Zepbound. Now,
And what made it big? Did Oprah make it big? Did the Kardashians make it big? Like,
no,
was it media that made it big? Why did it explode all of a sudden?
I saw it with my own eyes. COVID.
COVID
COVID
made it
made it
big.
big. And I'm going
Why?
to tell you why. Because for the first time, people with obesity, and we as a medical society got it, that obesity puts you in a risk mode, right? Before, we used to tell patients, if you don't lose weight in 20 years, you're going to develop diabetes, you're going to have complications, osteoarthritis, sleep apnea. But came COVID, a virus out of nowhere, and people with obesity were having the highest mortality,
Yep.
the more critical care visits. So patients with obesity got like a quick memo that the way that your body is right now is not in a healthy state. So
So being obese isn't a problem down the road. It's a problem now. And that's a
because
total
you're
culture change. Like we had the whole healthy at every size, don't body shame. People were being like, don't weigh me in the doctor's office, don't use it as a biometric. Like
yeah,
the pendulum really swung, and then it was like overnight, obesity is a health problem.
exactly, because obesity, the fat tissue puts the body in a chronic pro-inflammatory state. So if your autoimmune system is busy with the chronic inflammation of obesity, came a virus, you didn't have the protection, right, to protect you against this virus. So people with obesity got the message pretty quickly that you needed to change something. And I remember in my office having patients that would come to me and say, I need to lose weight. I don't want to die from COVID. So people were actually scared. So the demand or the change in perspective of obesity was there. And then we had the drug that will help the patient lose weight. So I call it the perfect storm. It was the perfect combination. The demand was there, and the goods were there. So that's what made this huge acknowledgement of GLP-1s and the benefits of them.
Very interesting. So GLP-1s are peptides.
So
Peptides are
GLP,
they're small. Correct me if I'm wrong, but I'm like they're peptides, which means it's like a small protein molecule.
yeah. So
Okay.
our own we make
We
GLP-1
make GLP-1s.
in our gut, right? And it's considered a hormone. So GLP-1
It's a
is
hormone.
truly, it's a hormone.
A hormone. Because it
And for
travels
this,
from one cell to another
exactly,
cell to communicate.
it takes messages, right,
Yeah.
to the organ that is going to have any activity. It sends a message of what it should do, and we have receptors, as we do for hormones, all over our body, in our gut, in our brain, in our heart, in our kidney. Our own GLP-1, once it's released into the bloodstream, it's broken down within 2 to 4 minutes by an enzyme. So that's our own one, right? So our own one was isolated for the first time in the 1980s by a physician in Harvard. Because our own one lasts only 2 to 4 minutes, they couldn't use it as anything for medication. But in 1992, a researcher in the VA hospital here in the Bronx, Dr. John Eng, isolated the first GLP-1 outside the human body, and this was in the lizard, in the Gila monster. And that GLP-1 was not broken down by an enzyme. So it was long acting. And that's the boom. That's what happened. Then it became patent. And actually, the story is really interesting. Dr. John Eng, who was an endocrinologist, brought it to Mount Sinai at the VA hospital in the Bronx to help him patent the drug. They said, no, we're not interested. He mortgaged his house to patent the drug on his own, and then took it to an endocrine society meeting, presented an abstract, and there Amylin, the pharmaceutical, was there and purchased the patent.
That's
Which is,
cool.
I think, is really interesting that
It
they
is
didn't
very
believe in
interesting.
him.
Did they not think like obesity was? They didn't see the like medical reason for having this drug.
At that moment, the only benefit that was seen was for glucose control.
Okay.
So they said, another diabetes drug? No. But look
Like, we already have metformin. It's the best.
Look what they missed out, no? I mean, this is the drug that will change everything, how we practice medicine and how we live.
Yeah. I mean, there's so many big topics, I think, with GLP-1. One of them that is exciting as far as midlife and hormones and should we take things for prevention is the data that, we've been screaming from the rooftops of hormones help keep the body healthy. Hormones help keep the body healthy. And now we're like, GLP-1 is also a hormone, and it's looking like it has data long-term for dementia, Alzheimer's, maybe prevention of diabetes. It's an exciting time because medicine's really being forced to consider come back. I mean, how many women are told come back when you're more sick?
Yeah, for sure. And this is, as a medical society, unfortunately, that's what we learned because that's what we knew, right? To treat all the complications, either from menopause or in this case for obesity, right? We had all the tools to treat type 2 diabetes, hypertension, high cholesterol, osteoarthritis, sleep apnea. We had everything else because we didn't have anything to treat obesity because we didn't think of obesity as a disease to begin with, right? We thought it was a willpower issue and the patient has to resolve on their own. But we find out decades later that actually obesity is a disease that is not the patient's responsibility or solely the patient responsibility of losing or gaining weight. And then now we can treat that. We have medications to treat the actual disease, and then we're going to prevent all the complications. So I really foresee that in the next 2 generations, we're going to have less type 2 diabetes. Probably in the future, we won't have type 2 diabetes, hypertension, high cholesterol. We build specialties in the complications of obesity. So really the way that we practice medicine is going to change. And finally, we can do some preventative medicine and not just treat the acute problem.
It's so exciting. Do you know, I'm in Facebook groups with like a lot of surgeons. Are the weight loss bypass surgeons, are the jobs hard to find now? Because I would think people are getting less surgery for weight loss now that these medications have come out.
Look, I've had patients, the most that a patient has lost with me is 160 pounds, right? And this is with medication, no surgery. And I have many patients that lost over 100 pounds or in high numbers of 80, 90 pounds that before we only used to see in surgery. And the beauty of it is that with bariatric surgery, you lose it within 3 to 6 months. Right, your body, you lose significant amount of muscle, and there's no way to control that, right? Because you go in a very small caloric intake from restriction. But with GLP-1, we can fine tune it that you don't lose muscle mass, and the only thing you lose is body fat. With GLP-1s, what we can do is body recomposition, which is the whole goal whenever we say weight loss, right? We want to do body recomposition, increasing your muscle mass and decreasing your visceral fat, because we know that low muscle mass increases all-cause mortality. So if we don't talk about muscle, we're missing the big picture. We don't say that about obesity or having high body fat. We don't say it increases your risk for all mortality, but we do have the research and the data that low muscle mass does increase all or risk for mortality. So whenever we're talking about body composition, muscle is as, if not more important than talking so specifically about and fixating on fat tissue.
Yeah, I love that. I think that's what a lot of the, I would say cautious, not skeptics, but cautious people about GLP-1s is the saying that you will lose muscle mass. And Lord knows, I just got a half a pound of muscle in the last half a month, and I'm like, that was the hardest gained half a pound, right? It's like,
100%.
and so when you think about like, oh my God, something's going to make me lose your muscle, like you kind of want to stay away. So what are people like you, what are the doctors doing to say, let's use GLP-1s and let's maintain the muscle mass? What do people have to be thinking about?
So first of all, every patient should have a body composition, right? Any patient that is thinking of doing a GLP-1, they need a body composition to really see what's what in your weight. What is it that you really need to lose? What's your muscle mass? And once you go on a body and a GLP-1, to not lose muscle, we need to increase your protein intake. So in reality, it's about 1 gram of protein per pound for ideal body weight. And through a body composition, we can kind of calculate what's your ideal body weight.
Yep.
And then also strength training, right? But I think I like to take baby steps with my patients. And the first thing that I want them to get a handle of is getting enough protein in their diet.
Yeah.
Because really, to preserve muscle, the bare minimum is protein. To
Yep.
gain muscle, then we can add the strength training or the resistance training. But for many patients, it's already a change being on a GLP-1. You want to let them adapt. And at the bare minimum, the first homework that I give them is to really measure and follow their grams of protein.
Good. Yeah, I've come into this recently where I think it's a mindset. Let me know. But people or women are like, that's just what I eat. That's just what I'm used to eating. It's kind of this like, it's partly cloudy today, instead of like, you actually have to think about food in a different way.
Yeah.
And not be like, oh, well, I only eat blah, blah, blah a day. Of like, you have to think about it differently. How do you help people realize like food's not accidental?
Well, it becomes almost with constant reinforcement, right?
Mm-hmm.
And also when my patient comes for their first follow-up after being on a GLP-1 is really eye-opening visit, because we do the body composition again, and there we can see if they truly are consuming enough protein as they think they are. If there was no muscle loss, then we're good. If they lost muscle mass, they know that they're not consuming enough protein. So it really clicks at that moment that we're all, and many times
Interesting.
they will overestimate the amount of protein. So
Yeah.
if they tell me, but I'm consuming so much protein and they still lose muscle, I say, okay, walk me through a day of your meals, of your
Mm-hmm.
protein. And you can always see that they were overestimating another 30 or 40 grams of protein a day. In reality, they were consuming half of what they should have consumed. And then that settles really well when they see it. They freak out a little bit, like, oh my God, I did lose muscle. It
Mm-hmm.
can happen. And then just a shift happens. And then every visit becomes, how did I do with my muscle? Did I save my muscle? It shifts the focus from weight loss to how am I doing with muscle, which is great.
Yeah, that's so fun. So, and it really, I mean, we have to get away from the number on the scale, like you said, is absolutely meaningless.
100%.
And muscle actually weighs a lot.
Yeah. Yeah.
Right.
I mean, yesterday in a podcast that I also did, they told me, what's the one test that you would tell women to have if they can only do one? And I said, a body composition.
Nice.
Because so much can stem from that result and from what it comes out, right? And we can improve so many things just by looking at a body composition that are going to spill into other aspects of your health.
Yeah. Well, I think the flip side, just to go off on the flip side of the GLP-1 people who want to lose the body fat, is the really thin woman. Thinness is associated with wealth, with status, with beauty, with, all of these things. And you're looking at like a sarcopenic person who's going to trip on the curb and break a hip. They've got osteoporosis, right? And so it's kind of this opposite but similar metabolic problem of like, you don't have muscle, you don't have strong bones. We actually need you to put on the pounds to be healthier.
Yeah, definitely. And many times they still have high body fat, but they look thin or small because of no muscle mass, right? So they're metabolically unhealthy because they have high body fat, and metabolically unhealthy because they have low muscle mass. So that's even worse than a patient with obesity and high muscle mass.
Right. Yeah, because they're strong. They're strong underneath all that.
They're strong.
I flew to Dallas like 2 weeks ago, and on the plane, the people who need the extra help, and they have the people in the wheelchairs, right? And it was
Hmm.
3 frail women in a row. It was just like boom, 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 and I was like, oh my god, we're staring at our future if we just think that we should just take the natural approach of like living however many days the good Lord has given us, is like it's assistance down the jetway.
Oh
Like
yeah, definitely.
very frail. Is there published data saying GLP-1s plus 1 gram of protein per pound body weight will maintain muscle? Do we have that
Not
published data?
yet. Not yet. And I have thousands of body compositions from thousands of patients, right? And that's what I'm writing my book.
Mm-hmm.
I'm giving everything that has worked for my patients, but you need the students, the residents. I if anybody
Yeah,
there listening, you want to
the
publish
research people.
data, come reach out to me.
I love it. Talk about doing GLP-1s without sex hormones versus people who take. So there's a couple published papers saying being on hormone, what I mean by hormones is estrogen, testosterone. Being
Yeah.
on sex hormones plus GLP-1s is sometimes more weight loss, but better lean body preservation because their hormones are replete. What's your experience with that?
Yeah, definitely. And my patients that are specifically with testosterone, my midlife patients or postmenopausal patients on testosterone, they can build muscle, right? They
Mm.
definitely build more muscle. I can see the difference in their body composition once they start on testosterone. Sometimes they gain 1 or 2 pounds of muscle without strength training, right? And
Yep.
and the protein and the nutrition needs to be there too, right? Um, but also with estrogen and progesterone, I mean, it's just, if you think about it, the patient will be sleeping better. You, when you weight train, when you sleep is when you build muscle, not when you're in the gym lifting the weights. But if you have a woman that is not sleeping through the night because of menopause, perimenopause, they're not resting, they're not recovering, and that will translate into not gaining muscle mass. So definitely being on hormones just makes the environment for you to succeed more likely.
Yeah, I mean, it's crazy the adoption of GLP. At this point, 1 in 5 Americans have been on a GLP-1, something crazy high. And you're like, the adoption of that, I know they've been around since '05, but like since COVID, right? The adoption of that compared to the adoption of estrogen and testosterone, which is 5% of Americans
Yeah.
have been on that, and 100% of women have low sex hormones at some point in their life. But we jumped on GLP-1s. They're just like so much sexier.
Well, because at the beginning, everybody jumped in hormones too, right? In the 70s and the 60s, everybody was on hormones, all women.
Yeah,
But it was that you can see the transgenerational damage from the WHO,
yeah,
right? Because anybody who's not on hormones or is thinking but not doing it is because cancer,
yeah.
because cardiovascular. So it's because of that headlines back then that it became very ingrained in our mothers, in the doctors that we've trained with. So it's going to take another generation probably
Mm-hmm.
for that to increase, because it's shocking that still 5% of women are only in hormones.
Yeah, it's crazy.
It's shocking.
And men are undertreated as well. I mean, I think that men should have a screening testosterone, maybe at age 50. I don't know. I haven't settled on a number yet. But the data we have for men and testosterone, it's associated with depression, low bone mass, dementia, diabetes. Like we have all that data. Why is it not a screening test? I think we're undertreating that gender as well.
Yeah, and we don't do bone densities in men, right? That's the reverse of in research in healthcare. All the research is in osteoporosis is the majority in women and not in men. So we say, yeah, there's osteoporosis more frequently in women, but because we don't study the men, right? So that's like the flip coin of what we experience as women.
Yeah, totally. Um, let's talk about endocrinology, endocrinologists, and their inability to treat sex hormones.
In endocrinology, now we say like GYN and OB is so vast, right? For an endocrinologist to like really focus on every hormone that we make in our body. So even in endocrinology, which is a specialty,
Of
people tend
hormones.
to of hormones, it's a specialty of hormones. Many people tend to lean into specific hormones. So they're endocrinologists that all they do is thyroid, right? There's endocrinologists that all they do is type 2 diabetes, and endocrinologists that they fixate in type 1 diabetes, and once in neuroendocrine prolactinomas, all the brain hormones, right? Uh, but sex hormones is like a gray area because we share it with GYN, we share this with urologists. So it's not as like we don't tend to fixate as much as that because we assume that there's other specialties also being checking them out for the patient, right? But the other hormones, it's really everybody leaves it to us. So I think that's the reason. And also,
I think you're
I
being
mean,
kind.
very kind, of course. I'm very kind with my people. I'm
But I
being
mean,
very kind.
the endocrinologists who do the sex hormones are like, these are hormones. We should know this. So my question is like, in your endocrinology fellowship, did you get trained in the sex hormones? Do they even train
I
you in them?
Yeah, I got training in menopause, and I
Mhm.
would say I was very early adopter. I mean, as soon as I got out of my fellowship, I was prescribing hormones. I was like, this is, I mean, because the data was already being questioned back then, right? Um, and seeing women suffer, and also my training in Mexico, we use hormones in women for perimenopause and menopause. So I really carried that with me, and I mean, and in medicine, like everything, there's going to be doctors that can look outside the box and doctors that won't. Doctors that are a little bit more, I don't want to say risk takers, but that we are willing to see outside the box and see, okay, it's not necessarily as dangerous as they can see, and it can benefit people,
Mhm.
right? So I think also being in academic medicine, if while doing academic training, that also limits you of thinking outside the box, right?
Yeah. Yeah.
I
I
think,
think from what I hear on social media, women feel so dismissed because they're like, I went to a hormone doctor and the hormone doctor doesn't do these hormones. And so they're kind of like,
yeah, but I also
maybe
see,
it's a marketing problem. Like, don't call yourself a hormone doctor, but you're right. Like, not all urologists take out prostates,
yeah, and
right?
not all GYN prescribe hormones,
Yep.
right?
Oh, well,
So
that's for sure.
I always tell women that tell me, how can I get somebody? How do I know? I said, okay, don't assume to begin with, right? Don't
Yeah, yeah,
assume that it's an endocrinologist. They're going to give you hormone replacement therapy. Don't assume that you go to GYN and they're going to give you hormone replacement therapy. The best thing you can do is ask. When you call to make an appointment, ask, does
yeah,
the doctor prescribe hormone replacement therapy?
yeah.
And that will be like the first indication of if you should go there or not.
That's what I tell women. Same thing. I'm like, don't waste your time. You don't want to find out once you're in the room.
No,
Like,
you want to find out
you've already
before.
paid for parking. Don't do that.
Yeah, and your time. I mean, and set up
Yeah,
your time apart and all of that, right? Just don't assume, don't make any assumptions.
I love
Call
that.
and ask.
So I'm hearing more about microdosing GLP-1s. Is there more published data on this? Is this just more that we should get more personalization in dose titrations because not everybody should take the same dose? And where do you think the data is going is just as far as metabolic health and really low doses of GLP-1s?
So this is what my answer to somebody who tells me, I don't need to lose weight, but I want to get the benefits from GLP-1.
Okay.
That's what I microdose.
Yep.
First of all, I want to have a body composition of that person and see if in reality you are metabolically fit and don't need to lose weight. I want to see that you have more muscle mass, that your percentage body fat is anywhere between 18 to 28, and that your visceral fat is low. I would say 9 out of 10 of people that say that, they actually have high percentage body fat, high visceral fat, and low muscle mass, right? But let's assume somebody is metabolically healthy, more muscle mass, less percentage body fat, less body fat. That tells me immediately that that person is doing everything the right way. They're strength training, they're doing resistance training, they're eating a lean protein diet, meaning low in sugar, low in carbs and starches. So my comeback is, you don't need the extra protection. You're already there where we're aiming to get with a GLP-1. But it's very different if you say, I don't need to lose weight, I just want the benefits, but then your percentage body fat is 35%. Then you will benefit from a GLP-1 at the first regular dose. Where I see the use of microdosing is going to be at the end of the road of a patient with a GLP-1, right? If somebody lost all the weight that they needed, all the fat that they needed to lose at the lowest dose, for maintenance, we can do half. We can do 1/3 of the dose of what you use to lose weight, right? So I see more the use of microdosing as maintenance, but
Okay.
not to get to the goal.
Got it. So the lower doses won't get you to the goal. Say you've got somebody who's like 32% body fat. They're like, I'm at the gym. I struggle a little bit with protein, but like I do my best. Little bit just to kind of get their body fat optimized.
Yeah, but you can do 0.25 of semaglutide, or which is Wegovy and Ozempic, that is
Mhm.
not as strong as the first dose as tirzepatide, right?
Okay.
So we can play around with what we currently have in the first doses. Also, microdosing came out of compounding GLP-1, right? Because the branded GLP-1 come in pre-dose form,
Mhm.
right? So that's another issue with microdosing is that you need the compounding version. But now Eli Lilly has a vial that we can manipulate in regards of the dosing. But again, for really weight loss, we need the therapeutic doses.
Got it.
For maintenance, we can do lower than the therapeutic doses. That's where the use comes.
Got it. Got it. Where do you think we're going as far as cost on this? I recently saw something that 7 out of 8 people who qualify for this drug can't afford this drug. Do you think with time and more people in the market, it's going to come down? Do you think insurance companies are going to be like, hey, this is actually cost effective because we're preventing disease long term? What do we say to the people who are like, $1,000 a month is out of reach?
Yeah. So, I mean, there's a monopoly right now between Novo Nordisk and Eli Lilly, right? Pretty much they are pulling all the strings right now, and they can do what they do because they can get away with it because they're the only ones. I think once other pharmaceuticals come with their own versions of GLP-1, then we will start seeing more decrease in the price, right?
Mhm.
I think also what I'm starting to see, and Eli Lilly did this, instead of a pen, they came out with a vial. So that decreased the cost from 1,100 in a pen to 300 in a vial for a month's worth, right?
Yeah.
So I think that also will decrease the pricing. The other thing is that both pharmaceuticals have manufacturing coupons that brings the cost down to half if your insurance is not covering for it, right? So you will pay $500 for a month's worth. The other part of the equation is educating people, right? We need to educate people that this is an investment in their health. Out
Mhm.
of everything they spend thousands of dollars through the years in crazy diets, crazy books, crazy detox, crazy exercise program, this is money well invested that for the first time, it's going to give you long lasting results.
I love it. Let's talk
And
again real quick about how it actually works. Our GLP-1 our GLP-1 that only lasts 2 minutes is produced in the gut. It sends a signal to the brain to say we're full. Is that how
so
GLP-1s work?
yeah, so we have receptors, right? Like receptors in the pancreas for it. And when your sugar goes above normal for somebody who has type 2 diabetes, this hormone sends a message to the pancreas to produce more insulin, right? So that was the first discovery or the first effect that was found of GLP-1. But we also have receptors in our gut. And with this hormone, the GLP-1 does, it increases our satiety hormones once we start eating. So you get fuller with smaller portions, and then it suppresses your hunger hormones in between meals. So for most patients, it looks like two small meals, physically content and satisfied through the day. Then in the amygdala, in the hedonistic eating and drinking area of the brain, we have
Mhm.
receptors too, where we eat for a reward. right? The hedonistic area is you anticipate a reward either from food or for some beverages for some people, right?
Yep.
It blocks the reward response. So there's no feedback of that reward anymore when you reach for that food in particular or that drink in particular. So it's out of your mind. The behavior changes. And then when you're hungry, you enjoy your food, but then you get satisfied with half a portion of what you normally would.
And that portion better be protein.
100%.
Got it. Yeah, I mean, there's promising data on GLP-1s and addiction. Like people are wanting to gamble less, they're wanting to drink alcohol less.
Yeah.
I think I haven't seen much in the sex med world, but there is some rumor that number one, sex life goes up because body image is better. Also,
100%.
especially in men, as they lose the body fat, their testosterone goes up naturally. So there's a higher sex drive that could happen. But then also losing the reward of the orgasm and the sex. And so desire might actually be affected by these drugs because you're like, yeah, I can take it or leave it. I'm kind of happy over here with my protein.
I have to say, I have not seen that.
You haven't seen it.
I
That's
have
good.
not seen that. I have not seen that. Actually, the opposite. There's increase in sex drive. I mean, if somebody's in perimenopause or menopause, then the answer could be different, right? It could be estradiol, it could be testosterone. But I don't see, I mean, the reward of the weight loss is so high that I don't think either patients don't complain about sex drive because they haven't not expressed that actually they express the opposite, that their sex drive improve.
Yeah.
Right.
Very cool. So if you can think, what's the most surprising result you've seen in your own patients using GLP-1s? Like beyond the scale, because you had 160-pound weight loss happen. Like that's incredible. But any other like surprising results? Yeah.
You know, that the majority of the patients want to get fit if they could, right? That the majority of patients really take to heart training, being strong. They do marathons, they climb mountains, they climb volcanoes. They just see their weight. For many people, it was something unreachable, something that they only dream of, something that was not a possibility, right? Maybe halfway in between, but not to the point of having a normal, healthy weight. So for when a patient achieves that, it's like, what else can I achieve, right? It's my mind is not consumed with my weight. Then you have room. There's room for creativity, room. I mean, I've had patients get promoted. Other flip is divorces. I have several patients.
Tell me about that.
That they get divorced during
the
treatment.
They say, I was staying in this relationship because of my weight. I didn't think I was otherwise lovable. I didn't think so. I was
I could reach for more. I mean, I guess I think that's mostly the explanation, right?
Yeah.
I don't think it's the cause of the divorce. I think it was just something that it uncovered.
Yeah.
And interesting enough, the patients that get divorced, then they keep coming to me, and then they bring me their significant others as patients. And then sometimes I have like, okay, let's make sure we not have the four of them at the same time.
Well, that's good. That's good proof that you provide good care as you're bringing in the exes and the new people. What do you think one of the biggest misconceptions with GLP-1s is as far as safety? You know, people will throw up, thyroid cancer, pancreatic cancer, bowel obstruction was the big thing when it was starting to get big, and for like the surgeons were worried about that. Anesthesiologists were like, you have to be off GLP-1s for like a whole week before you can have general anesthesia because of the gut slowing down. What are the biggest like misconceptions, and can you kind of share day-to-day risks with these medications?
Yeah, definitely. So I think one of the biggest misconceptions is that they're new medicines and we're not going to know what's going to happen in 5 years and 10 years. You're going to grow an ear from your cheek. I mean, it's things like that, right? We have the data for 30 years now. The other misconception is that anybody can prescribe it, that it's just a skinny shot. So anybody can prescribe it, right? A med spa, an ophthalmologist, a neurologist. I mean, anybody can prescribe it just because they can. I can prescribe chemo drugs and I don't do it because
Right.
because I can't. I don't have a clue. I'm going to create more damage
Yeah.
than benefit. So I think there's a misconception that these drugs are easy and anybody can prescribe them because everybody wants a piece of the pie right now, right?
Yeah.
Economically.
Well, and if you
Uh,
look at how many people there are to help, if you look at just, what, 80% of the nation's overweight.
yeah. And there's only 9,000 obesity physicians. And we need all the help we can. I cannot see everybody, nor I want to say everybody, right? But do it responsibly. If you're going to be prescribing this medication, do it responsibly. Take some courses, get a body composition machine for your office. There's ways to do it the right way, right? I think that's one of the biggest misconceptions. I mean, a lot of the other headlines that we see in the news, definitely, I've never seen in my clinical practice, bowel obstruction. So this tends to be from taking overdosing,
Yeah.
from constipation. I mean, the way of the medication, it slows down digestion. So it also causes dehydration. So if those are not proactively prevented individually, then you're going to have this, right? But again, this depends, the safety depends on the expertise on who's prescribing you this medication.
Love that. What for a doctor who's listening, who's like, no, my patients are asking me, I want to do it best of practice. Is there a great place to go get a course that you can do online? What would you recommend?
Yeah, definitely. So I would recommend the Obesity Medical Association. They have great courses, virtual courses, live courses, books, everything. Also, the Obesity Society, right? Go to one of the conferences, either the Obesity Society, which is once a year, or the Obesity Medical Association, which is 2 or 3 times a year, depending. And it has the bi-coastal. So there are resources for them to get informed without having to go 2 years into fellowship with obesity.
Right. Yeah. Oh, I love that. Do you think they're going to be formulating these to be able to be swallowed, or subcutaneous buccal to get absorbed that way, vaginal route, right? Like for your needle phobes, or to get the cost down? Where do you think the future of drug development? From what I'm reading, they're very interested in oral, but it takes a much higher dose of the drug to get it in because it's processed orally. So that's why it exists the way it exists.
And you'll be very surprised. The oral version is extremely expensive, almost as the injectable. So we do have an oral version of Ozempic. It's called Rybelsus, and it's for the use of type 2 diabetes. And this was approved in 2019. So we have 6 years of an oral version of it. The reason that you don't hear it as much is because we never saw anything similar in regards to weight loss as the injectable, right? We saw good glucose control comparable to the injectable, still as expensive as the injectable. And to reach the higher doses for us to see significant head-to-head weight loss as the injectable, patients don't tolerate it. They're struggling to tolerate the current doses. So it's interesting to see what's going to be the tolerance on the higher doses. Just to give you perspective, the current oral doses is 3 milligrams, 7 milligram, and 14 milligram. What just got accepted the application by the FDA last week is a 25 milligram dose. And 2 years ago, the 50 milligram dose was studied, but patients were not tolerating it, right? So it's going to take time to get somebody to that point to tolerate the 25 and the 50 milligram dose if we ever can. And
Yep.
cost is not that's going to be cheaper, unfortunately.
Got it. Yeah. Interesting. So metabolic markers, you think every woman should check yearly? A1C. Yep.
A1C, lipid panel, lipoprotein A, ApoB, right?
Yep.
I think those are thyroid hormone, definitely once a year. That should be done regularly.
If you see a woman who's got high cholesterol, say she's starting on estrogen and the hormones, what are you recommending, like diet wise, for these? Because I think the old school of like low fat is falling out, but it's like we don't want to put my understanding is we don't have primary prevention data for statins. A lot of women don't want to be on statins. What advice would you just give a woman who's like all of a sudden their cholesterol's up? Besides get on hormones, because I can lower it by 20%.
Definitely wait and see once we start hormones, right? That'll be like the chemical part that let's let the hormones do what they can do, and
Hmm.
then we'll recheck before starting any statin. I mean, I rarely start anybody on a statin. Um, and then also what changes can we do in your diet, right? I mean, definitely increasing lean animal protein is going to help. Um, and exercising, definitely, we do have data that exercises decreases LDL. And then omega-3, right? I mean, the good fatty acids, but then that can go into the lean animal protein, right? Salmon, whitefish. Um, and then wait and see, and then repeat your lipid panel not earlier than 3 months, and then see what really happens. For the majority, it comes down.
Nice. And I know triglycerides are associated more with carbohydrates, high sugar diet. So when you see triglycerides, you should be thinking, let's cut the carbs down, get rid of the
Exactly.
processed food. Does the same hold
Exactly.
true for cholesterol, or is that more a triglycerides?
Triglycerides definitely is telling me about insulin resistance, is telling me that you run the risk of prediabetes. Of course, if they were fasting, triglycerides is the only one that really we need patients to be fasting to really see it as a true value. Um, and many times it's familial hypertriglyceridemia, right? So many times the patients still need medication. Uh, but triglycerides is more diet control, that meaning changes in your diet can have the most effect in your triglyceride level than any other of your cholesterol markers.
Love it. Tell us about your book, December 30th.
So my book is pretty much my care that I give my patients. I know that I'm not accessible for everybody, and I cannot see everybody, even if I was. So this is I'm doing this for the people that don't have access, not just only to me, but to good medical care with a GLP-1, to help them even from choosing the right doctor. Where are the green flags, the red flags to look for when you go to a doctor, when you call to make the appointment, to the moment that you reach your goal. And I dividing my book in 3 parts. The part 3 is something that is my favorite part of the book, because it's something that we are just learning. So for the first time ever in history, we are having masses of a population lose weight and reach their goal, right? We're finding that once they reach the goal, there's a lot of adjustments to do, not only physical, psychological, socially, culturally, that we are not prepared to guide the patient with once they get there, because again, for the first time, they're able to get there. So for the majority of patients, it's happiness, it's something successful, it's something that is celebrated. But even in that celebration, there is anxiety. Many patients get so scared and anxious that they're going to regain the weight, that they're going to run out of the medication, that there's going to be a shortage of the medication,
Yes.
that their rug is going to be pulled out of under their feet, right?
Yep.
Many patients tell me, I see my body, I see myself in the mirror, I don't recognize myself.
Yep.
Like the psychological part
The brain
takes
hasn't
root.
caught up to the
It hasn't
new.
caught up with the physical part, right?
Yeah.
The physical part happens, we can palpate it, but the psycho, I mean, you're having patients that struggle with their weight for decades, right? Some patient told me, oh, people are nicer to me now. And it makes me question, was I not worth before for people to be nice to me, right? Many times people assume that their close relatives or the loved ones are going to be happy for them, but sometimes that brings their own projections of somebody who's trying to lose weight, and they're seeing this person now lose weight and eat healthier and exercise, right? So it's really interesting, the post of reaching the goal.
That's gonna be so good, and I think so necessary, and I think so missing from the toolbox of like, this is what everybody wants, right? And to realize, there's a book called When Sex Hurts, and at the end of that book, there's a chapter of what do you do when the pain's gone, right? Because your whole
Yeah,
world was set up because of something, and that something's gone now. And
yeah,
and so I thought that was brilliant, and that sounds like what you're trying to do with your book is like,
yeah,
how do you keep moving, or
yeah.
what's the new goalpost, or how do you reorient?
And that it's okay to have those emotions, right? I mean, it's okay to not feel 100% happy. It's okay to say, okay, now that I got here, now what, right? It's okay. And the purpose of that book is just to walk you through that. And I've seen and I've learned all of this through my patients, right? And through the close follow up, because when you lose follow up, and that's what happens with bariatric surgery many times, right? You have the surgery, you lost the weight, you lost the follow up, nobody's following you. But what I'm doing with my patients is when I'm able to do is really build this relationship that I see my patients continuity after they lose the weight for maintenance.
Mm-hmm.
And that's where I'm hearing all this feedback, right? And we're learning as we're going. So that's what I wanted to show in my book is like the experiences that I'm seeing after years of following patients.
I love that. So everybody follow her on Instagram until her book comes out. What's your Instagram?
Dr. Salas-Whalen, DrSalasWhalen.
Perfect. I'll put it in the show notes too, so we don't have
Thank you.
to so we don't have to struggle. So 2026, that means I'll have read the book and then come on again and we'll talk about it and we'll talk more. We'll update to days of like, is the cost still crazy? Are people still having access? What's new after a half a year's gone by? So
yeah. Well, no, my book coming this year, 2025, December 30th,
right, but the end of
yeah.
December, right?
End of December.
Yes.
So
Okay. So we'll get a turn of the year. We'll get you back on. Any final thoughts for people and GLP-1s and seeking care that you want to leave them with?
I would say don't leave a GLP-1 as your last resource, right? Don't spend mental if you're losing weight, maintaining your weight feels like a full-time job, you definitely will benefit from a GLP-1.
I love that. And bonus points if you can be with somebody that can be there with you to take it, because it's not, I see a lot of people in my practice, because my practice is a year-long membership, because I believe in the same relationship, doctor-patient relationship that you believe in. And I see a lot of them from like, the Medi spas or the IV infusion place is like they buy like a 6-week, 8-week, 12-week Ozempic thing and then it's done. And then they're kind of like, realize like this is a lifestyle. This might be longer. And then there's other things to deal with afterwards. And the body composition too.
They don't even do body compositions at the med spa. They have them come every week to weight themselves. But nobody knows if they're losing muscle, if they're losing fat, where are they losing, right?
Yeah. Body composition. I get that on every single patient of mine. It's a game changer. Yeah. It's so insightful.
And I think we're going to change the weight loss is going to become body recomposition.
I love that.
That's the goal. Body recomposition.
I love that. Muscles are sexy as hell too.
Oh,
By the way, people. By the way, they're very sexy. All right. Thank you so much for joining us today. Until next time, thanks for coming on.
Thank you.